So today we're going to talk about categories of disabilities and best practices to help meet the needs of students that fall within those particular categories. So first, just a review, we've talked a lot about special education, and obviously we should be attempting every other type of intervention, and before a student is referred for assessment and evaluation, and wherever possible, of course, we should be meeting the student's needs within the regular education program. So one important distinction that I want to make sure you understand is the difference between an accommodation and a modification. So in accommodation, you can provide both in a 504 and an IEP. And so this is something that an intervention that supports the students completing the same task as anyone else, right? So it's the same curriculum, it's the same assignment. The only thing you might change is potentially the format, right? So reading something out loud to a student rather than expecting them to read the print, maybe extended time on testing, maybe in a different setting, etc. A modification you can only provide within special education, right? So a student within a 504 would not qualify for modifications. And modifications is where you're actually changing the task so that you have a different standard. So for example, in special education, you might have a student where you actually modify the curriculum and you modify the reading level so that the expectation for them in that classroom is a third grade reading level versus a fifth grade reading level, right? So you're actually creating modifications to what they're expected to do versus an accommodation where you're expecting them to do the same thing as everyone else, but you're supporting them in being able to accomplish that task. So that's just an important distinction. So remember, 504s, accommodations, special education, both accommodations and modifications. So emotional disturbance, we talked about this in class. This is one of the types of disabilities that you would likely be involved in assessing and determining, right? And these are just the categories under special education that you would have to meet one or more of the following to be able to qualify for an emotional disturbance. Learning disability, of course, I'm sure you all know this, but it's not the same thing as mental retardation. A specific learning disability involves one of the processes in using language, spoken or written, mathematical calculations. It could be perceptual problems, a result of a brain injury, etc. It does not include children that have a learning problem as a result of a visual, hearing, or physical disability, emotional disturbance, right? So you have to rule out those other categories in order to qualify for a specific learning disability. Students qualify for learning disability at age 9. It's a very sort of stringent criteria, or they may qualify a little bit earlier, but there's a sort of a new criteria that's applied at age 9. So for example, students transitioning out of having the label of developmental disability at a younger age. And so of course you do have to have low achievement, and the student is not achieving at expected levels given their cognitive ability, instructional history, and environmental factors. But it used to be the expected versus performance IQ, so what they can do versus what they actually do, and that's what's changed. So you can no longer use this discrepancy formula. It has to be based on a lot of data, right? And that's why we go through the whole kind of RTI process and in different sort of types of interventions with students to look at, to sort of exhaust all different options that we may have for how to work with them and how to support them in the general ed curriculum. About 50% of students who are in special education qualify under learning disability. Their high school graduation rate is lower compared to non-disabled peers, 62% compared to 88%, so there is an issue of equity there. The primary mental health concerns for students with learning disabilities are self-concept and social skills. So those are the two areas you're likely to work with students on who have learning disabilities. Um, Elementary students' self-esteem, the research shows, will benefit most from academic intervention, not individual counseling. So a lot of times it would not be um, indicated to actually provide individual social work minutes to an elementary school student with a learning disability. Um, Middle school and high school students, their self-esteem does benefit most for counseling. So you might use small group instruction, etc. Optimal length of social skills groups, the research suggests, is about 10 weeks. So you might include some of those students potentially in a social skills group. But it's important to know that with elementary students, it's not necessarily the best thing to pull them out of class and provide counseling to them. They're going to do best when they feel good about themselves because they're receiving academic support and interventions to help them be more successful. So some of the best practices might be, of course, the screening of these students, right? Interventions with parents to help them adapt to their parents' learning disability. So you might, with these children, for example, work with the parents so that so that they understand sort of how to help them with the homework, or how they might break down tasks for them, etc. The direct intervention might be things like bibliotherapy, so you could potentially do that in the classroom, using bibliotherapy to teach social skills. You might use a form of CBT adapted for younger kids. You might have peer intervention, right, tutoring, those kinds of things for those students. With students in this particular special education category and mental retardation, and unfortunately that's the language that's used in the special education criteria, but this is where you have significantly sub-average functioning, both intellectually and adaptive behavior. So when you're doing this assessment, you might be using the Vineland for assessing kind of their level of adaptive behavior when there is a concern about an intellectual disability, which is the terminology that I prefer to use. Approximately 5% of the school population is in this category. They typically do require special education. Some of the challenging issues for us as social workers around working with students in this particular category are the challenging behaviors that they may have, right? So they may have aggressive outbursts, self-abuse, and doing sort of behavioral interventions, functional analysis of behavior is important, manipulating the settings, modifying the curriculum, helping teachers to work with these students might be some of the best approaches. So again, not necessarily the direct intervention with the students, but a lot of times intervention in terms of looking at the setting, doing the analysis of behavior, working with parents, working with teachers. So you might do consultation a lot, like with the students with learning disabilities. You might, working with the parents, right, and setting up kind of part of the minutes as consultation minutes. In this case, you might also have some consultation minutes. Then you have students with physical disabilities, right? And so these are either temporary or chronic conditions that affect the student's ability to walk, their strength, their motor or sensory abilities, their ability to communicate. It can be different medical issues, right? Like asthma, convulsive disorders, hemophilia, heart disease. So a student in some of these categories may very well not qualify for special ed, and maybe a 504 plan is going to be enough. On the other hand, it could be that they do qualify for special education services. So for example, there's been students with spinal cord injuries who just have a 504 and do not qualify for special education. So this doesn't necessarily mean that they automatically qualify for special education. They just might need different accommodations and really no modifications, and then a 504 plan is enough. The important thing to remember with students with physical disabilities and with any other population, but particularly in this case, is the philosophy of self-determination, right? And letting that process guide you. So what are their needs? What do they determine their needs are? and how can you sort of support that process. So here you want to make sure you are ensuring sort of the integration, access, that you want to provide any sort of educational workshops for people that may not understand the disability. Again, the consultation, right? Team building, supporting families, collaborating with hospital or medical providers, and again, collaborations between special ed and regular ed teachers. So again, in this case, you might not have to work a lot directly. It might be more consultation minutes and supporting families and doing educational activities for staff. And again, thinking more about the issue of rights and integration and access. Autism is going to be a much more common disorder you're going to be working with and expected to understand a lot more about. It's much more common, right, to have students on the spectrum. It's a very complex disorder, of course. You have an incredible range of functioning within this population or category. Some of the symptoms that that would be most primary would be the impairment in social interaction, right? Impairment in communication, and then some of the other things like repetitive movements, fixed on a certain interest, those kinds of things. So some of what happens with students with autism is that they have really uneven learning abilities. So they may have some certain skill levels that require individualized instruction. You might be involved with applied behavioral analysis. That's sort of the most widely accepted effective intervention model. Also assisting with the social skills, right? So a lot of times you might use social stories with a student with autism. In this case, really medication is not justified as the first line of treatment. It's really recommended that behavioral treatments and social skills are probably the best types of treatments. Applied behavioral analysis is a really common approach, and this is where behavior is taught in very systematic steps, right? So you give a specific cue and a prompt, and then when the student responds appropriately, they're immediately rewarded. So it's based on behavioral and learning theory. So in terms of some mental health issues that you might be working with that might also qualify students for special education under OHI or potentially under emotional disturbance, or ADHD, that's incredibly common, right? And you have students, everything from 504, so just the 504 plan, to students who actually qualify under OHI for special education, issues of depression, bipolar, pervasive developmental disorder, which is another term for autism or Asperger's, different conduct disorders, and anxiety disorders. So with ADHD, of course, a lot of these students have a lot of challenges, right, in daily living and interactions with family, with peers, and some of the difficulties they have, of course, are sustaining attention, organization, mood swings, poor memory, impulsivity. So here again, you might be working directly with the student. You will probably be working a lot with the classroom setting and the teacher, and modifications. Here's some of the things that they might be doing in the classroom, right, that makes it really difficult for them. And I've actually found when students with ADHD students in the classroom, it helps a lot to do sort of solution-focused therapy at the classroom level, because you're not sort of singling out a particular student, and then you're using a lot of positive sort of reinforcement when you give feedback in this particular model. So the solution-focused, right, you're going in the classroom, you're setting a classroom overall kind of classroom goal, and then students help each other to meet that goal, and then you go into the classroom and you observe, and then you provide feedback. I noticed that today you sat in your seat for 10 minutes without interruption, or you politely asked for help, or so, but you're giving all the students that kind of feedback in terms of the positive things that you observed in the classroom. This diagnosis should be collaborative, should use a rating scale. I unfortunately have seen the diagnosis very flippantly kind of used and diagnosed. I had a student that was hospitalized once, and the doctor asked the parents, oh, geez, your child have a hard time focusing on homework. And the parents said, yeah, she has a really hard time sitting at the table and doing her homework when everybody's in the living room watching TV. Well, duh. If any child is probably going to have a hard time doing that. So she was diagnosed with ADHD. If they would have done a really comprehensive assessment, done rating scales at the school with teachers at home, probably she would not have been diagnosed. And then of course they recommended medication, because this was not a student. She was a student where maybe there were some depressive symptoms, but certainly not ADHD. So I really have seen kind of some very poor practices around the diagnosis of ADHD. So some of the interventions, of course, that have been found that are typically used, and I have to actually, there's a lot of research on even pharmaceutical interventions, that they're not, in the short term, they have some benefits, but in the long term, there are no sort of differences between a student on medication and a student not on medication. I know that's sort of a very controversial issue, but in terms of long-term studies, it doesn't show that that a student is better off, and in some cases they're actually worse off when they're on medication long term, because it affects their ability, their social interactions, and then that has negative consequences for them and their self-esteem and those kinds of things, because they don't tune in as well to social cues when they're on medication. In the short term, there are benefits, right, in terms of being able to sustain attention longer and those kinds of things. And there are also no academic differences. So a student on medication does not do better academically in the long term overall, right? I mean, there's always kind of very specific kind of individual situations, but in terms of overall comparison, some of the other approaches that have been used are CBT, behavioral training, of course, working with parents a lot, the parent training, teacher training, so a lot of classroom management, a lot of consultation, behavioral monitoring, accommodations for those students, really addressing their strengths and limitations, but focusing on their strengths, because a lot of times that's not the focus for these kids, right? Because there's a lot of frustration sometimes with kids that have these symptoms in the classroom. So, so those are the different sort of major issues that you would be, both in terms of mental health issues and special education categories that you'd likely encounter. So I would encourage you to sort of think about, as you're thinking about interventions for these different categories, sort of what are the best practices, and making sure that the interventions that you're choosing do line up with what we know are some of the best practices for these approaches. Okay, thanks.